picture this. You have a perfectly healthy 47-year-old woman. No real medical history, no daily medications, nothing.
Right. Totally baseline healthy.
Exactly. And then
Yeah.
about 3 weeks ago, she notices her eyelids just feel a little heavy.
Which, I mean, anyone would just write off as being tired.
Right. But then she starts getting double vision when she looks to the side. And a week after that, her voice gets this nasal quality to it.
And that's already a huge red flag.
Oh, for sure. But then comes the climax of this whole 3-week descent. She literally wakes up in the middle of the night, suffocating.
Wow.
Yeah, by 6 in the morning, her husband is rushing her to the ER because she physically can't even, lift her arms above her head.
It is just a breathtakingly fast decline. I mean, the speed alone is alarming, but the underlying mechanics of what is actually happening inside her body are, well, they're even more shocking.
Which is exactly why we're doing this deep dive today. We're looking at a stack of really fascinating clinical case notes and a landmark New England Journal of Medicine trial.
Yeah, the MGTX trial.
Right. And our mission today is to track how a single, totally dormant gland somehow managed to orchestrate 4 simultaneous life-threatening conditions in this one patient's body.
It's wild. Understanding how a complex biological system fails like this, it will fundamentally change how you think about the hidden machinery of your own immune system.
It really is a masterclass in clinical deduction. So let's start right at the bedside in the ER.
Okay, let's do it.
This patient is rapidly declining, right?
Yeah.
And before anyone can even start looking for tumors or rogue glands, they have to stop her from suffocating.
Exactly. You have to secure the ABCs first. They need to figure out exactly where her body's communication system is, breaking down.
And the physical exam gives them a roadmap, right?
It does. She has bilateral ptosis, which is just heavy drooping eyelids, and it's worse on the left side. Plus that diplopia, the double vision.
Which is so interesting because the notes say it resolves if she just covers one eye.
Right, that's a classic sign. She also has that nasal voice, and her proximal arm strength is down to, a 3 out of 5.
But the real detective work starts with these 2 specific bedside tests. And the first one is just incredibly simple.
The ice pack test.
Yes. I love this one because it sounds like, a total home remedy, but it's highly scientific.
It really is. The doctors basically take a standard ice pack and just hold it against her drooping left eyelid for 2 minutes.
Just 2 minutes of ice.
Yep. And when they take it off, her eyelid magically lifts by more than 2 millimeters.
Okay, but how does ice fix a paralyzed eyelid? I mean, structurally, what is happening?
So it all comes down to the neuromuscular junction. That's the tiny gap where the nerve actually talks to the muscle.
Right, the communication relay.
Exactly. Nerves send this chemical messenger called acetylcholine across the gap to tell the muscle to contract.
Yeah.
But you also have an enzyme there called acetylcholinesterase.
The cleanup crew.
Yes. Its entire job is to sweep away and break down that acetylcholine so the muscle can eventually relax.
Okay, so where does the ice come in?
Well, that cleanup enzyme is highly temperature sensitive. When you apply the ice pack, you cool the tissue down, which severely slows the enzyme's activity.
Oh, so the cleanup crew basically goes on a coffee break.
Exactly.
Yeah.
And because the enzyme is sluggish, the acetylcholine just lingers way longer in the junction. The muscle receives more of the signal, and boom, the eyelid lifts.
That is so elegant.
It really is.
Yeah.
And that response is pathognomonic, meaning it's definitively diagnostic for a neuromuscular junction dysfunction. Like, no other cause of a drooping eyelid responds to ice that way.
Okay, so they know the junction is the issue.
Yeah.
But they still have to rule out other, terrifying conditions.
Yeah.
Which brings us to the second bedside test checking her reflexes.
Right. So they take the reflex hammer, they tap her knees and elbows, and they find her deep tendon reflexes are 3+.
Meaning they're strong.
Very strong. They are symmetric and perfectly preserved. And this is honestly the single most critical finding in the whole initial exam.
Because it completely rules out Guillain-Barré syndrome.
Right. Exactly. Guillain-Barré is the closest mimic here. It causes the same kind of rapid proximal weakness and respiratory failure in otherwise healthy people.
But the mechanism is totally different.
Completely different. Guillain-Barré destroys the myelin, which is the protective insulation on the peripheral nerves themselves.
So it's like someone taking a pair of wire cutters and just snipping the telephone wire outside your house.
That's a perfect way to look at it. The signal never even makes it to the building. You get no ring, no reflex. Reflexes are lost super early in GBS.
But this patient's reflexes are totally preserved. Her telephone wire is perfectly intact. The issue is purely at the neuromuscular junction.
Exactly.
So it's more like having a flawless wire, but it's plugged into a completely broken telephone receiver in the house.
Yes, and in this case, her own immune system is the one actively smashing that receiver to pieces.
Wow.
Because her reflexes are intact, they know the nerve itself is fine. The lesion is strictly at the junction. This presentation tells the medical team they are dealing with myasthenia gravis until proven otherwise.
Okay, so they know it's myasthenia gravis. But here is where the medical team faces this sort of hidden cliff.
Oh, the visual trap.
Yeah.
Yeah.
If you just look at this patient, she is awake. She is alert. I think the note said she had a Glasgow Coma scale of 15.
Yep, fully alert.
She is literally talking to the doctors. It feels so completely counterintuitive to think she's like moments away from total respiratory collapse.
But that visual appearance is an incredibly dangerous trap. In neuromuscular respiratory failure, your standard signs of distress like blood oxygen levels and respiratory rate are highly deceptive.
Because she just physically can't show them she's struggling.
Exactly. A patient with a failing diaphragm literally does not have the muscle strength to breathe faster. Their oxygen will look perfectly normal on the monitor right up until the exact second they stop breathing entirely.
Man, that's terrifying. By the time you see her CO2 levels rising, which hers actually are, it's a late, ominous sign.
Yeah, by then the respiratory muscles have already failed.
It's like driving a car down the highway, right? The speedometer reads 60 miles per hour, everything looks totally fine on the dashboard, but you have a massive hole in your gas tank.
Right, you're running on fumes, but you don't know it.
You're going to keep cruising right up until the exact second the engine completely stalls, with zero warning.
Which is exactly why critical care doctors cannot rely on visual guesswork here. They use a strict quantitative safety net called the 20-30-40 rule.
So this rule tells them the exact physiological moment they need to intubate and get her on a ventilator.
Precisely. It removes all the subjectivity.
Okay, so let's break down what we're measuring here. Because if the oxygen levels are lying to us, this has to be pure mechanics. Does the 20 stand for lung capacity?
It does. It stands for forced vital capacity, or FVC. If the volume of air she can forcefully exhale drops below 20 milliliters per kilogram of body weight.
Which is what, about 1 to 1.5 liters in an adult?
Roughly, yeah. If it drops below that, you are in the danger zone. Her FVC is 1.1 liters. She is teetering right on the edge of that threshold.
Okay, so if 20 is the sheer volume of air, I assume the 30 measures something different, like the actual muscle strength required to pull that air in.
Exactly right. You're measuring the negative inspiratory force, or NIF. Now, a normal NIF is very negative, around minus 70 or 80.
Because you're pulling a strong vacuum.
Right. The danger threshold is if it becomes less negative than minus 30 centimeters of water. Her NIF is minus 18.
Oh, wow. So she has officially crossed that threshold. Her inspiratory muscles are critically weak.
Very weak. And following that logic, the 40 has to be the exhale, the peak power to push the air out.
The peak expiratory flow.
Yes. If it drops below 40 liters per minute, that is the third red flag. Hers is markedly reduced.
So she has crossed 2 of the 3 thresholds, plus her CO2 is rising.
Yeah.
So she has to be intubated immediately.
No question about it.
But, I think a lot of people might wonder why intubate. Like, why not just use one of those tight-fitting CPAP masks? Non-invasive ventilation just seems so much less drastic for someone who's still, awake and talking.
It does seem that way, but non-invasive ventilation is strictly contraindicated here.
Because of the nasal voice.
Exactly. Remember that from the physical exam. That nasal voice indicates bulbar dysfunction, basically weakness in the muscles of the mouth and throat.
Right.
If you put a highly pressurized mask on someone who cannot swallow properly, they can't maintain the seal. But more importantly, if they vomit, they have absolutely no ability to protect their airway.
Oh, man. So the risk of aspirating fluid directly into the lungs is massive.
Huge risk. Intubation is literally the only secure option for her.
Okay, so they secure her airway. The immediate threat of suffocation is finally paused. But they still need to find out why her neuromuscular junctions are under attack in the first place.
Right, they have to find the source.
So they do a chest CT scan, and it reveals a 4.2 centimeter mass in the anterior mediastinum, which is the space in the front of the chest.
And whenever doctors find a mass in that specific location, they automatically run through what's called the 4 T's to figure out what it is.
Right, the differential diagnosis. Teratoma, terrible lymphoma, thyroid mass, or thymoma.
Yep. And in an adult, a thymoma, which is a tumor of the thymus gland, is the most common. Crucially, it is the only one of the 4 T's associated with myasthenia gravis.
The thymus. I always have to think of this gland as like an elite immune system military academy.
That's a great analogy. Usually it produces highly disciplined T cells.
But it seems this tumor has totally corrupted the academy, right?
It has. The tumor fundamentally disrupts the whole educational process. So the T cells graduate, but they're abnormally programmed. They basically become rogue, autoreactive assassins.
That is terrifying. So this single corrupted gland unravels a massive multi-system breakdown in her body, triggering these three distinct paraneoplastic syndromes.
Yeah, and the first one is called Good syndrome, which is an incredibly rare acquired immunodeficiency.
Because these rogue T cells start turning on the body's other defenses, right?
Exactly. They actively suppress the development of B cells, and B cells are the factories that manufacture your antibodies.
So she has no antibodies.
When they check this patient's blood, she has less than 1% B cells. Her immunoglobulins are critically low. She has virtually zero antibody defense.
So she is completely undefended against, like, basic bacteria and opportunistic infections.
Totally defenseless. She requires lifelong intravenous immunoglobulin replacement and prophylactic antibiotics just to survive daily exposure to common pathogens.
Just to exist in the world. And here is the truly tragic detail from the notes. Removing the tumor doesn't cure Good syndrome.
No, it doesn't. Even after the thymoma is gone, the immunodeficiency remains a permanent condition.
Man. Okay, so that brings us to the second hidden syndrome, pure red cell aplasia. Because her blood labs also showed her hemoglobin was falling super fast, making her severely anemic.
Right, and when they look at her bone marrow activity, her reticulocytes, which are the young red blood cells, are near zero.
But her white blood cells and her platelets are completely normal.
Exactly. There's no internal bleeding, and her mature red blood cells aren't being destroyed in the bloodstream.
Her bone marrow just isn't producing reticulocytes at all, meaning no new red blood cells are entering the system. The precursor cells are being selectively assassinated.
Those rogue T cells from the corrupted academy have selected a very specific target. They infiltrate the bone marrow and systematically destroy the exact precursor cells that turn into red blood cells,
while leaving the white cell and platelet factories entirely alone.
The precision of the destruction is just staggering. And taking the tumor out only induces remission in about 30% of these cases.
So what happens to the other 70%?
They require a really powerful immunosuppressant called cyclosporine to specifically target and shut down those autoreactive T cells.
Okay, so let's recap where we are. She's suffocating on a ventilator, she has a permanent immunodeficiency, and her bone marrow is literally shutting down her red blood cell production.
It's a crisis on every front.
Right, and the instinct has to be fix the breathing first so she can get off the breathing machine. But if I'm reading these case notes right, standard treatment protocols here would actually kill her.
Oh, it is a complete minefield. The most obvious, intuitive treatments will cause catastrophic damage if used incorrectly.
So where do you even start?
You have to start by identifying the exact antibody causing the myasthenia gravis. Her blood work shows she is anti-AChR positive.
Which means what exactly?
It means the antibodies are physically blocking the acetylcholine receptors at the junction and using the immune system's complement cascade to just destroy the tissue.
And it's crucial they confirm that. Because if she had been positive for a different antibody, say anti-MuSK, the whole treatment protocol flips.
Entirely. Anti-MuSK antibodies don't attack the receptor directly. They attack the structural scaffolding that holds the receptors in place.
Oh, interesting.
Yeah. So if it were anti-MuSK, a common myasthenia drug called pyridostigmine would actually worsen her symptoms. Plasma exchange would be definitively preferred over IVIG, and a drug called rituximab becomes the first-line treatment.
But her anti-AChR positive status introduces a completely different set of traps. And the biggest one seems to be that pyridostigmine trap.
It's a huge pitfall.
Because this drug stops the cleanup enzyme, right? Leaving more acetylcholine in the junction to stimulate the muscle. You'd naturally think, she's weak, she's in a crisis, give her more of the drug to make her stronger.
It is a very natural clinical instinct, but escalating it during an active crisis will result in what we call a depolarization blockade.
Wait, if more acetylcholine makes the muscle contract, how does having too much suddenly paralyze it?
Because the receptors at the neuromuscular junction get bombarded so continuously by the massive excess of acetylcholine that they literally just shut down.
They just get overwhelmed.
Exactly. They become refractory. The muscle can no longer respond at all, and the patient gets paradoxically much weaker.
It's like flooding a stalled engine with too much gasoline. You think you're giving it the fuel it needs to start, but you actually just choke the entire system and the engine completely seizes up.
That's exactly what happens. And worse than that, the excess acetylcholine hits other receptors all over the body, triggering SLDGE syndrome.
Okay, I have to ask, what does SLUDG actually stand for?
It is an acronym for salivation, lacrimation, which is tearing up, urination, defecation, gastrointestinal distress, and emesis, or vomiting.
Basically, your body starts uncontrollably leaking fluids from literally everywhere.
Yes. And in this specific context, the most dangerous part of SLEGE is the massive increase in airway secretions.
Oh, no.
Right. You have a patient who is already intubated on a ventilator, and suddenly their lungs are rapidly filling up with thick
That
fluids,
is a pure nightmare scenario.
which is why you hold or reduce the pyridostigmine. You do not try to force the engine to run. You have to focus on clearing the bad fuel, the antibodies themselves.
And you achieve that with immunotherapy, right? Specifically plasma exchange known as PLX or IVIG.
Exactly. But that brings us to another huge trap, the sequencing trap between PLX and IVIG.
Because PLEX is essentially like a dialysis machine for your plasma, right? It physically filters the pathogenic antibodies right out of the blood.
Yep. One single exchange session clears 60 to 70% of the circulating antibodies. It works very fast, which is why it's preferred when you're trying to get a patient strong enough for surgery.
While IV, on the other hand, works a lot slower. You're infusing donor immunoglobulins to modulate and quiet down the hyperactive immune response.
Right.
Think about how incredible this is for a second. We usually think of our blood as just, carrying oxygen around. But when they hook her up to this PLEX machine, they are physically filtering out millions of microscopic rogue assassins.
It really highlights how our blood is fundamentally an active battleground.
It totally does. But wait, here's the conflict. She needs PLEX for the myasthenia crisis to clear the antibodies quickly. But she also has good syndrome, meaning she has zero antibodies of her own and desperately needs the IVA to survive.
And this is where the fatal error happens. A well-meaning doctor looks at her low immune labs, panics, and decides to give her the IV while she is in the middle of her 5-day PLEX course.
But PLEX removes all plasma proteins.
Exactly. If you give a patient a super expensive multi-hour infusion of IVIG on Tuesday and then hook them up to the PLX machine on Wednesday, the machine will literally wash 70% of that life-saving IVIG straight out of their blood and into the medical waste bin.
It literally washes the medicine down the drain.
Yes. You must entirely finish the PLEX course, wait until all the bad antibodies are washed out, and only then initiate the lifelong IVIG replacement for the good syndrome.
Okay, so they navigate that. The crisis is managed, the antibodies are filtered out, and she is finally breathing on her own. So why not wheel her into surgery today? I mean, she still has a literal tumor in her chest.
You'd think so, right?
Does the oncological urgency really take a backseat to the neuromuscular disease?
It absolutely does, and understanding the nature of her specific tumor explains why. This tumor is classified as a Mesoka stage I thymoma.
Okay, and Mesoka staging is just how they evaluate how far a thymoma has spread.
Exactly. Stage I means it is fully encapsulated. It has not invaded the surrounding tissue, the pleura, or the blood vessels at all.
So it's contained.
Very contained. From an oncological standpoint, a stage I thymoma is not an emergency. The prognosis is actually excellent once it is removed.
But operating on her right now would be bad.
It would be incredibly lethal. Operating on a patient with unstable myasthenia gravis is so dangerous. The anesthesia and the sheer physical stress of surgery can easily throw them right back into a respiratory crisis on the table.
So you just wait.
You wait 4 to 6 weeks after the crisis fully resolves. She needs to complete her PLEX, hit her respiratory targets, getting that forced vital capacity safely above 2 liters and her NIF back to a safe range. And she must be perfectly stable on long-term immunosuppression.
And reading through these notes, even the long-term medication has its own traps. Let's look at prednisone. It's the absolute backbone of myasthenia treatment, but in the first 1 to 3 weeks of taking it, about 50% of patients experience a transient paradoxical worsening of their weakness.
Yeah, the medicine temporarily alters the transmission at the neuromuscular junction before the actual immune-suppressing benefits kick in.
It gets worse before it gets better.
Exactly. Because of this initial dip, you never start high-dose prednisone in a patient who is bordering on that 20, 30, 40 threshold unless their airway is already completely secured.
Wow. Then there is azatioprine, which they use to help taper patients off the steroids eventually. It takes like 12 to 18 months to actually start working. But before you can give a single pill, you have to check the patient's TPMT enzyme levels.
Thiopurine methyltransferase. It is the enzyme responsible for actually metabolizing the drug.
And if a patient is deficient,
If they are deficient in TPMT, the standard dose of azafrine will accumulate to toxic levels and cause life-threatening bone marrow suppression.
so if they lack the enzyme, you have to completely pivot to a different drug like mycophenolate.
Yep, you can't risk it.
And if they fail all of that, the notes mention this highly targeted drug called eculizumab.
Right. Eculizumab is a monoclonal antibody that inhibits a very specific part of the immune system called complement.
Which is basically a series of proteins that cascade to destroy invaders.
Exactly. But if you disable complement, you also disable the body's primary weapon for punching holes in a specific type of bacteria called Neisseria meningitis.
Meaning without complement, you are entirely defenseless against meningitis.
Which is why you must administer a meningococcal vaccine before ever starting eculizumab. If you don't, the patient is at a massive risk for a lethal brain infection. It requires such a deep understanding of molecular cause and effect.
It is a staggering sequence of molecular dominoes.
Yeah.
But let's fast forward a bit. It's been 6 weeks. She's stable. She goes to surgery. They take out the thymus and the tumor. Obviously, this is good because, she had a tumor.
Right.
But let's look at the MGTX trial from the New England Journal of Medicine in 2016. Because this trial showed doctors are now removing the thymus in myasthenia patients, even when there isn't a tumor at all.
Yeah, that trial totally changed the landscape of treatment. It proved that in generalized myasthenia gravis, even a perfectly normal-looking thymus is actively generating the pathogenic antibodies.
The residual thymic tissue itself is the enemy.
Exactly. By performing a thymectomy, patients had drastically improved symptoms, they needed way less medication, and they stayed out of the hospital compared to patients who only managed it with medication.
So for our patient, the surgery essentially cures the oncology issue by removing the stage-out tumor. And it treats the neurology issue by removing the actual antibody factories.
2 birds, 1 stone.
Let's bring this deep dive full circle. You have a 47-year-old woman who goes to the hospital just because her eyelids are heavy, and that one symptom unravels a 4-part catastrophe. A neuromuscular breakdown paralyzing her lungs, a hidden immunodeficiency leaving her totally defenseless, a targeted bone marrow shutdown stopping her red blood cells, and a tumor.
All orchestrated by one tiny walnut-sized gland, the thymus.
It's unbelievable.
If there is one practical takeaway from all these sources, one thing for you to remember above all else, it is the absolute necessity of the 20-30-40 rule.
Specifically checking that negative inspiratory force.
Right. Yes. Because as we saw, a patient can look perfectly fine, awake, and be actively talking to you while secretly standing on the very brink of suffocation.
It really makes you look at the human body so differently. And, I want to leave you with a slightly eerie, provocative thought to ponder. The thymus is an organ that is primarily active when we are children. Its job is to educate our immune system, and then, as we reach adulthood, it's supposed to shrink, turn mostly into fat, and quietly retire.
Just fade into the background.
Right. But if a retired, seemingly dormant childhood organ can suddenly wake up decades later and systematically dismantle a person's neuromuscular, immune, and hematologic systems, what other dormant biological remnants in our bodies are quietly capable of completely rewriting our physiology?
It's a crazy thought.
It really makes you wonder if that heavy eyelid is just tiredness, or the first signal of an ancient system waking up.